All right. Well, I wish I could stand up here and tell you that I had very exciting news, because I keep hearing more and more about new studies with adults. But the reality is that in pediatric dermatology, we need to move forward, and we need to move forward more quickly. And I'm very excited that the IPC has a new group that's going to specifically be paying attention to pediatric psoriasis and helping to advance that. Now, we all know that pediatric psoriasis is not rare. We see a lot of it, most of it in individuals who are adolescents, but we can also see it pre-pubertally. And a certain percent in various studies are mild to moderate, that's most, but certainly there are many, many who are moderate to severe and deserve our special attention. We heard earlier about the problem with underdiagnosis or misdiagnosis. Well, this is a huge problem in pediatrics, and I want to emphasize that one of the issues is that we aren't even seeing patients with psoriasis because they're not being sent to us. That delay in diagnosis is huge in pediatric psoriasis. I don't think that the numbers are quite as bad as what the Australian group has presented, saying that only 9.4% are correctly diagnosed, but nevertheless, the majority are incorrectly diagnosed by referring doctors, atopic dermatitis, seborrheic dermatitis, dermatophyte infection, and that is in part because many of the patients do look a little bit different in their manifestations from what we see with typical adult psoriasis. Now, if you look at the center, you'll see these well-circumscribed erythematous scaling plaques that everyone would, of course, call psoriasis. But many of our patients, for example, have facial involvement, up to almost half of patients with facial involvement, sometimes the sole manifestation. And very commonly, we don't see these well-circumscribed plaques, but rather a more diffuse-looking erythema and scaling as shown in some of these patients. And you can imagine why it may be difficult for someone who's not familiar to make that diagnosis. And often it's what we might call more of a psoriasiform dermatitis. I'm showing you many examples here of psoriasis in children, many of which were misdiagnosed. I want to mention that when we think about special areas like the scalp involvement, very common in children, in a study we did a decade ago, up to 79%, and 79% in that study had scalp involvement, more often in girls than in boys, perhaps reflecting the Koebner phenomenon. We also see nail changes in almost 40% of patients. Here in our study, more in boys than in girls. And of course, I mentioned the facial involvement being something that one can see alone or certainly with other sites, but more often than what we see in adults. Now, pediatric psoriasis, of course, can be a huge problem in terms of quality of life. We just did a large systematic review where there's no question with several studies, study after study, showing the reduction in quality of life associated with pediatric psoriasis. And this can be anything related to social functioning, stigma, bullying, to having symptoms, particularly itch and especially scalp itch in children. Disease exacerbations are particularly uncomfortable and highly visible, leading to increases in anxiety and depression, not only for children, but also for the parents of children. There's a tremendous impact on self-esteem, and of course, with so many patients being adolescents, this can have a lifelong effect and follow them into adulthood. We also, of course, see the comorbidities that can occur. I'll mention those in a minute. And I want to emphasize again that when we're talking about pediatric psoriasis, we're not just talking about the individual child, but also the entire family with frustration, fatigue, anxiety, depression, financial stress noted by the entire family. One more comment about the itching. Itching is actually seen in the majority of children, and 39% have experienced pain or stinging as well. But this itching tends to be not quite as severe as the itching of atopic dermatitis. So I think it's been something that's been ignored and hasn't been thought to be as impactful as in atopic dermatitis, with a lesser impact, for example, on sleep. Nevertheless, we should be asking about it and making sure it's part of our tracking of our treatment. Well, what about comorbidities? We hear a lot here about arthritis. It can occur in children, but it just is so much less common. So about 1% of cases, and actually in many studies, significantly less than 1%. We do think about it. We actually have ways to screen while we're actually doing the skin examination, and we take it very seriously. But actually, children often have issues with their joints that are not arthritis, and we need to be thinking about what is truly arthritis, get the proper kids to rheumatologists, and otherwise work with the pediatricians. Inflammatory bowel disease is increased, particularly for Crohn's, but the big problem that we see as a comorbidity in children is obesity. And the obesity correlates with the severity of the atopic dermatitis. In a country like the United States, where there tends to be more obesity, we see that much more obesity in the children who are affected. The important point to make about obesity is that in virtually all cases in which there's overweight or obesity, it is there at least 2 years before the onset of psoriasis. It persists at the time of psoriasis diagnosis. It's still there 2 years after. We need to do a better job in thinking about how we can alter the obesity and the lifestyle, because this is a driver for the onset of psoriasis and greater severity. There are many treatment guidelines out there, including more recent guidelines specifically on pediatric psoriasis put out by our American Academy of Dermatology, and fortunately some new topicals. So I'm not sure exactly what's come to Europe yet, but of course everything that we've had for so many years for treating pediatric psoriasis has been based on what's out there first for adults. There have been virtually no studies that are good studies looking at the many topical corticosteroids that we use or other additives, other than maybe some now on some of the calcipotriene, in particular calcipotriene steroid combinations. But the emerging topicals to me are very exciting because, of course, we want to treat most of our children with topical medications. In the United States, at least, we now have daily roflumilast cream, 0.3%, which has really very much transformed our access and ability to treat with agents that are not steroids. We also have a foam that's available, the cream to 6 years and up, the foam for seborrheic dermatitis for 9 years and up, but we've also been able to use that as a way to treat scalp psoriasis, which of course can be very challenging to treat, both from the concept of clearance, but also from the concept of what people are willing to use and adhere to. There is a phase 3 trial moving forward now to extend this to as young as 2 years of age. Now, tapinarof, which is an aryl hydrocarbon receptor agonist, is also available in the United States for treating psoriasis, but only for adults. But I'm expecting in the next year to see this go down in age to 6 years and above, and then subsequently 2 years. So really exciting to have new nonsteroidals beyond the topical calcineurin inhibitors that we've used for years, which really work well for the face and genital region, but not so well for other areas. Now, moving beyond topical therapy, phototherapy is still out there. We continue to use it when it's convenient enough for the family to be able to adhere to the regimen. Home units have also come out, but they're costly. At least in the United States, they really require having some experience first with phototherapy and showing it to be effective. But the big problem is adherence, because it is very difficult, especially when parents work and children have all their after-school activities, to do phototherapy. And as we've seen, it really is not as effective as some of the newer modalities that we have. What about other systemic agents? I will say that retinoids are out there. We're often required to use them for what's called step therapy in the United States, but I largely will use systemic retinoids in combination with other medications, particularly when there's palmoplantar involvement or other areas that are particularly hyperkeratotic. I will say that cyclosporin used to be my go-to, but particularly now with new agents out there, I can't remember the last time I put a patient with plaque psoriasis on cyclosporin. I want to stress that methotrexate is a great medicine, and we use it extensively for pediatric psoriasis. We've had decades of experience that has shown it to be safe, and it is much less costly than biologics. The problem with methotrexate is that it is slow, and that for many children you cannot achieve the same levels of effectiveness that we can see with the biologics. I love this study that came out many years back with 25 children who were followed on methotrexate. And I think if you look at this graph, you can see that when we're looking at 12 weeks, which of course was the endpoint for most of our biologic studies, that by 12 weeks out, PASI 75 is only occurring in 40%, and of course much lower. PASI 50 is only occurring in 40%, and of course much lower for PASI 75, which takes much longer then to get to that 40%, only being reached by 8 months, and PASI 90 in a small percentage. Now that said, it is oral, which offers an advantage. It rarely causes issues that require discontinuation. We feel very comfortable with its use, and I have had many patients who have cleared quite nicely after a few months of methotrexate. We continue to use it. The administration of folic acid, of course, is very important. I understand in Europe it tends to be used once a week. We use it 6 to 7 times weekly at a lower dose in the United States, and it has been shown to reduce some of the risks like the gastrointestinal risks. And overall safety risks very low with methotrexate. So I don't think we should throw it out, but of course we've moved towards understanding the pathogenesis and introducing biologics. Now the list of biologics in children remains much less than the list that we have available for adults. It seems to take about 10 years after something comes out for adults before we finally get it for children, and that's really been unfortunate. So I'm showing you here the EMA approved and the FDA approved medications, and you'll notice that many of them don't have a box around them because we're still stuck where we were several years back in terms of what's available, but that is certainly changing. We've seen progressively better efficacy for psoriasis in children as we've moved into the IL-23 Th17 targeting with ustekinumab, secukinumab, and ixekizumab. Just to show you the ustekinumab studies from 6 to 12 years, because this is now approved for 6 years of age and above, weight-based dosing, really very safe from what we've seen, and excellent results that we've seen. And I will also mention that ustekinumab is often our treatment of choice for one reason. It's very effective, perhaps not the most effective, but very effective, and it's only given every 12 weeks. And for pediatric patients with an injection, which even for adolescents sometimes is a struggle, this is an important criterion for us. So we use this medication extensively because of that. And for most of our patients, it just works beautifully. I haven't had a single side effect in any of the patients that I've ever treated with it. Now, what about CARD14 mutations? Well, I'm going to just show you these data and then move into a few comments about that. So these are just quickly showing you, as we've moved this forward to 52 weeks, that we see tremendous results with respect to the physician global assessment, the PASI 75 and the PASI 90. So this continues to be a very, very effective medication with only that every 12-week administration, which is great for kids. Now, monogenic psoriasis is really quite uncommon, but something that I want to put out there because when we're thinking about children, we need to think about CARD14-associated papulosquamous eruption. We've called that CAPE. This is due to activating mutations in CARD14. And the reason I mention it is because if you have somebody who comes in with psoriasis starting particularly in the first year of life, you should be thinking about this disorder. I have seen children who've had onset later. For example, the boy you see on your left first presented to me with erythroderma and some pustules at 8 years of age, but we then discovered he had a family history with a younger brother, misdiagnosed as an ichthyotic disease, but nevertheless with the same process. So not always in the first year, but most are. And this is one to recognize because there's no remission without treatment, and it is more challenging to treat with only partial responses unless you can get to the IL-23 or Th17 inhibitors. Just to tell you a little bit more about this, if you're not familiar, most often features of either psoriasis or pityriasis rubra-pilaris, and sometimes an overlap, prominent facial involvement involving the cheeks, chin, and often the ears, usually sparing the periorbital area, but I've seen some patients misdiagnosed as ichthyosis because of associated ectropion in severe cases, and usually truncal involvement, which is often patterned. And I point to the one on the right, a beautiful patterning following Langer's lines here, really reminiscent of pityriasis rosea, but showing in others more confluent areas with skip areas, as we might see in a PRP. And this is now recognized to be a cause for atypical or type 5 PRP in children now. Now, there can also be arthralgias and arthritis associated in severe cases, as shown in this picture. Now, moving on to the Th17, I think you're all aware that ixekizumab is available now for 6 years and above with moderate to severe psoriasis, based on the studies I'm just quickly showing here. Again, weight-based dosing, but excellent separation versus placebo, and long-term evidence of being able to sustain. It was mentioned before, these newer agents beyond the TNF inhibitors, we're really not seeing as much of the development of neutralizing antibodies, and although we've had to move some patients from one to another, it's really not as often as we were doing with the TNF-based inhibitors. A little bit more about ixekizumab here in Europe. It was pitted against etanercept, and of course, we were so excited about etanercept when that first came out, but that result pales in comparison to the Th17 inhibitors. The concern we have with Th17 inhibitors may be the development of Crohn's disease and the development of Candidol. In the studies with ixekizumab, there were a few patients who developed Crohn's disease. Is this because we're dealing with teenagers here in this population, and we know there's already an increased risk if they have psoriasis, or is this really related to the disease, to the medication itself? And I think the verdict is still out there, but the numbers are really very few, and I have yet to see this in my real-life experience with any of the Th17 inhibitors. This study did not show any increase in Candidol infections, with secukinumab, again, down to 6 years of age, showing the studies that were done with that. And as you can see, again, dramatic difference both against etanercept and also, of course, against placebo, as we look even at the PASI 90, particularly at the PASI 100, getting some very good results with this disease, with this agent, and following us out to 52 years, seeing good maintenance of control in patients. And in the secukinumab studies, there were a few with Candidol infections, but excellent results as well on quality of life, and only about 2%. I think this probably occurs more in women with vulvovaginal Candidol infections. It has rarely been a problem with children. So typical patients, I'm not going to spend time on this other than showing you the type of patient that comes in, often overweight, often with a history of plaque psoriasis that is just recalcitrant. I want to point out that many of these patients are bullied, are teased. It is imperative that we treat these kids aggressively to get them as clear as possible. In this case, topicals not helpful, which is often the case, although I'm hoping with some of the newer agents we can see better results. And the parents, in this case, were worried about methotrexate. We talk about methotrexate and how benign it is, but nevertheless, we certainly do see better results with the biologic. This child went on a biologic and did beautifully. So the risks of the biologics are really just largely that we just don't know the long-term effects. We have seen very little, if at all, in terms of side effects now having kids on biologics for years and years. The infrequent dosing, it makes for convenience. We certainly barely do any labs, largely baseline. The efficacy keeps getting better. Probably the biggest issue is that they are injection, and for some patients who are needle phobic, or certainly some of the younger children, that is an issue, but haven't even been seeing increases beyond that with psoriasis as a whole in terms of infections. The other big issue is cost. And it's a cost to society, if not to the individual. But fortunately, most of our patients are able to get these through their insurance and do very well. So TNF inhibitors, a few comments, still requiring annual TB monitoring, and in general, still more frequently required weekly or every other weekly for the TNF inhibitors. So we're not using them that much, particularly in children who so rarely will have the associated arthritis. Ustekinumab is a go-to because of the every 3-month injections and less concern about infection, and the Th17 inhibitors also only once a month, so quite convenient and minimal in terms of the injections, but there is that potential risk, perhaps, of inflammatory bowel disease and candidal infection, but very, very low. Again, for card 14, the IL-23 Th17 should be the go-to for moving forward with treatment. I want to show this because I think it's very important, now that we have an opportunity to do better, to ask the question, is PASI 75 enough, or is there a better impact on quality of life for these affected children if we can strive for PASI 90, PASI 100? And as you can see here, there is a statistically significant difference in improvement in quality of life if we can get to PASI 90, PASI 100, so that should be our goal now. Now, I'm showing you a list of biologics. You'll recognize them. They're all available and have been available for a long time for adults. Not a single one of these is yet available for children, but I'm happy to say that trials are ongoing for all of these right now, and I hope they come into the pediatric space very soon. What about orals? It would be wonderful to have more orals, especially because of the needle phobia of so many of our children and teenagers. We've got a Premolast, and we finally have some data I'll show you in a minute on that. But I'm excited to note that deucravacitinib is in clinical trials now for pediatric patients, and hopefully will be available for that group in the future. And I'm very excited about a new IL-23 small molecule inhibitor in which great results were reported for adults, and trials are ongoing now in pediatric patients. And finally, I'll just end by just showing you the apremilast data that were just recently reported in the 6 to 17-year-old group with moderate, the majority of patients, to severe psoriasis stratified by age group. And as you can see, patients were treated twice daily for 16 weeks and then went into an open label phase. Clear difference between the apremilast and the placebo group. But as you notice, if you look at these, even though we can't really compare head to head, the bottom line is that just getting to PASI 75 occurred in 45%, PASI 90 in 25%. So we're just not going to see the same effects that we're seeing right now with the biologics, with this agent, and hopefully we'll have even more effective agents orally in the future. But a good choice to consider when you have patients who don't have the most severe disease and for whom an oral agent is preferred. I do want to mention, again, the GI issues, as we well know, with apremilast do predominate, but rarely have caused for withdrawal. And with that, I will conclude that psoriasis in children is different morphologically from that in adults, but the central pathogenesis is similar with respect to targets. Every time we've had a new agent for adults, it's worked beautifully in children. Having these targeted and safer therapies that doesn't require blood monitoring now lowers the bar for us for systemic treatment for moderate to severe disease, including for the hard-to-treat areas, reaching PASI 90 and 100 now, and thereby further improving quality of life. But I do want to say that we need to understand much more in pediatric psoriasis. We don't know whether early initiation in more severe disease will reduce the risk of developing comorbidities, the later development of arthritis or cardiovascular disease. That remains a big black box. We also don't even know if earlier intervention will lead to the ability to then go to remission and remission without therapy later. These need large prospective studies, and we don't even have a registry for pediatric psoriasis, except at individual institutions. So one of our calls is to again look retrospectively and prospectively to figure out some of these questions. But I hope that by doing some of these studies, we will be able to significantly alter the course of pediatric psoriasis and its comorbidities in children. And with that, I thank you for your attention.